This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast and our special 2026 feature on headache. 2025 was a remarkable year for headache medicine, from influential new guidelines to highly anticipated clinical trial results, expanding real-world evidence, and emerging therapeutic targets. There is so much to unpack. I'm joined today by Patricia Pozo-Rosich, neurologist and head of headache and craniofacial pain unit and director of the Migraine Adaptive Brain Center at Vall d'Hebron University Hospital. Hi, Patricia. How are you? Thank you for being on our Neurology podcast.
Hi, Tisha. Thank you for the invitation.
Last time we saw each other was the International Headache Congress in Brazil. That was fun.
Oh, yeah, indeed. It was a nice way to catch up and be updated with all of the science.
Why don't we start there? What do you think some of the more promising talks and lectures and research discussions were?
Probably we could group in three big areas what we have learned. The first area for me would be coming from preclinical research. So what have we learned from animal models? And I wanted to highlight a couple of important papers I find. One was published in Brain, and it actually measured the efficacy of MEDI, so MEDI 0618, which is the antibody targeting PAR2, and how it actually works for preclinical models of migraine. So this is an important paper, I find, because, as you might know, anti-PAR2 trials are currently being done in migraine, and we are starting to understand how, if we are lucky enough to get phase 2 and 3 then trials through, how this might work. And we do that by understanding how this molecule and how the antibody actually will work in first animal models and then move towards human beings. So just as a summary, because this might be a new molecule that we will talk about a lot in the future of migraine, this PAR2 is the protease-activated receptor type 2 molecule, and it is widely expressed in mast cells, meningeal neurons, fibroblasts, and endothelial cells. It is a transmembrane G protein coupled receptor activated by proteases. And really, it's interesting to see in this paper that I'm mentioning how it increases CGRP release, how it actually helps or modulates the sensitization of dural nociceptors, and it's also involved in the development of pain and mechanical allodynia. And actually, by pre-treating these animals with anti-PAR2 monoclonal antibody, what they really measured was all of the specificity and potency of the monoclonal antibody to actually understand that it probably looks like, at least from animal models, that its effects in vitro, so in cells and animal models, both really inhibit the PAR2-induced calcium signaling. And this gives us a lot of insights for probably in the future understanding how this hopefully new therapy that is being currently studied in migraine works. So I would say that the conclusions of this Brain paper would be that MEDI 0618 is effective in preventing allodynia in CGRP-dependent and independent migraine models. So this gives you a way to understand that it's not only related to CGRP pathways. It's interesting to understand how its blockade offers new broader therapeutic strategies. And just for everyone to be aware, we are studying this antibody currently in phase 2 trials. So let's keep our alerts and let's see if in 2026, so the summary of 2026, so next year in 2027, we might have positive information in regards to this phase 2 trial. And the other preclinical, I would say, paper I wanted to highlight is in relation to the link that has been found also in mice, so in preclinical models of migraine, with endometriosis. Endometriosis is, as you perhaps all know, the presence of endometrial cells outside of the endometrium, outside of the uterus. And these lesions create a lot of pain and they actually can bleed. It's actually quite a complex, you would say, disease, which is very recently starting to be properly understood. And actually, within these studies, of course, it affects more women than men, or only women, you would say, of course. But like migraine, it has been associated as a comorbidity of migraine. So this paper published in Cephalalgia in 2025 by the group of Frank Porreca mainly showed all of the effects that endometriosis has in migraine mice models. And it's interesting because it helps us understand also how the presence of endometriosis might be linked to an increase on all of the sensitization of the migraine geminovascular system with the presence of allodynia, but not only trigeminal but also corpalgia, you would say, also this extracephalic allodynia, the abdominal allodynia, and the effect that endometriosis has, according to this paper, might be linked to the increase in prolactin levels and the prolactin receptor expression in these mice models. So to conclude, I would say that endometriosis increases vulnerability to migraine by prolactin-mediated priming of trigeminal neurons, and probably, this is their hypothesis as authors, the blockade of the prolactin release with dopamine D2 agonists, such as cabergoline, may be useful for the treatment of migraine in women with endometriosis for the future. So these two papers talking about some future possibilities on how new therapeutic targets might be looking are interesting, and both have been published in 2025.
Yeah, that is really interesting to see that moving beyond CGRP, looking for novel targets. As we know, migraine is a heterogeneous disorder, and there may be patients, and to think about endometriosis as a comorbidity, really just tailoring the treatment paradigm for these subtypes.
Then, if we would move on into some more translational research projects, I would like to actually this year concentrate a little on highlighting many papers that have been published in the different both headache and neurological journals on the relationship between migraine and other comorbidities at a genetic level. So we have, for example, this paper published in Headache that looks into the relationship between migraine and Parkinson's disease. And I would say, summary is that there is no genetic correlation between migraine and Parkinson's, according to this 2025 paper published in Headache. Then another important paper studying the relationship between migraine and stroke using the huge UK biobank and Megastroke GWAS as databases where all of the information comes from. And very interestingly, this is a paper written or published in Human Genetics, and it actually shows that perhaps migraine is more correlated to hemorrhagic stroke rather than ischemic stroke. So I thought that was interesting. I'm not sure if we can really grab into that, but at the genetic level, that's what they found. Then migraine in relation with depression, also studied through genetics, has seen that there is a very strong genetic correlation between major depression and migraine, something that we already knew, but so a new paper published in Nature Communications understands a bit further through different statistical models, so using deep learning, discovering then through the migraine GWASs all of the depression genes. Another paper published in Cephalalgia looked into the risk of having migraine and epilepsy. So again, using the UK Biobank, that is written by a different group, shows actually that there is no increased epilepsy risk for patients who have migraine. So that's also an interesting finding. And then moving a little more into epigenetics, we've seen, I would say, a couple of very interesting papers published. The first one in the Journal of Headache and Pain, where a group of authors published a study where they have done an integration of epigenetics, this is DNA methylation, to profile the risk genes for migraine and their subtypes. And what they found was that actually enriched in CGRP signaling, axon development, and neurovascular pathways were enriched in this Mendelian randomization. It's a different way of studying genetics with different types of analysis, but actually understanding that methylating DNA can have or could have a causal role in migraine risk. So this gives you a further insight that epigenetics are important for migraine. So migraine, yes, very hereditary disorder that goes in your DNA. But then depending on how we actually take care of ourselves, the epigenetics are modulated by treatments, by life experiences, by diet. So all of these things probably also have an importance on triggering migraine in certain individuals. And the final, and I probably think it is the most important study that we have published this year, led by the group in Taiwan, by Sujung Wang as last author and Shipin Chen as first author. They are working in understanding whether if microRNAs can capture migraine state activity and genetic risk. And what they found was that plasma microRNAs across ictal, interictal, and chronic migraine were different, understanding that epigenetics, again, probably is influencing the different states and helps regulate whether if a patient has actually, for example, more of a chronic migraine type or less, more of a, you would say, episodic migraine. And that might be linked also to how our epigenetic controlling system is working. And finally, I would probably, in this kind of translational part of 2025, highlight all of the reform imaging studies. The reform is, I would say, very comprehensive study led by the Danish Headache Center, and they have been publishing, and I am sure they will continue to publish, their database, which they have studied in many different ways, through imaging, through CGRP presence, through genetics. But in this 2025, they have focused their publications from the Reform MRI studies on imaging. And for now, according to their findings, as again, I repeat, they come from Denmark, it seems is that there is no clear structural alterations in migraine. However, they do see inflammatory functional changes in migraine. So again, migraine being an inflammatory functional disease that changes or might change structure, but in a dynamic way, and it doesn't seem to be permanent or related to degeneration. So that in relation to all of the translational findings that I thought were interesting for 2025.
Yeah, that's a great review. I think a lot of surprises there in terms of the genetic connection with hemorrhagic stroke, which we usually see more of a relationship, at least many studies show a relationship, especially migraine with aura and ischemic stroke. And then this idea of migraine and epilepsy, and maybe the relationship is not as strong as realized, at least on a genetic level. All of this is very interesting. How do we approach our patients with migraine and depression? And as we're counseling patients and maybe even considering treatments to really consider that comorbidity, all of this is very interesting. And also, as you mentioned, this chronic migraine, which many studies have not really shown a strong genetic relationship when comparing chronic migraine to episodic migraine. And maybe we should be thinking about epigenetics.
Exactly. Yeah. Epigenetics probably are going to be a key modulator for a disease like migraine that actually, as we all know, starts and stops. It has a very paroxystic way of presenting itself. So every now and then we have an attack, and then the frequency of those attacks, how does that get increased or decreased? So probably the key modulators to that lie in epigenetics. And epigenetics, as you have heard, are being studied both with DNA methylation and, for example, microRNAs.
So what should neurologists take away from some of these comorbidity genetic studies when counseling patients?
The first step is to be aware. You have to be aware that the migraine is probably a syndrome, and not in every patient it will express itself the same way. So you might have certain genetics that then are or aren't expressed in certain ways. But it clearly seems that migraine is related to depression. And we also know from a different study that was published a bit earlier in time that it is related to obsessive compulsive disorder a little bit, and also ADHD, so attention deficit disorder. When I learned that as a clinician myself, this actually helped me understand a little bit how migraine individuals a bit are. And that also stresses my interest in also making sure if those comorbidities are present in that individual, that they are properly treated. And then it has also opened up my mind because I've started to see and realize that in many families, some individuals get migraine, others get, let's see, ADHD, others get both. And you start to see these complexities on how probably same genetic backgrounds are phenotypically expressed in a different way depending on each individual of the family. That is probably some way of looking into it. In relation to Parkinson's, and we were saying also epilepsy and so on, it confirms my personal impression. I don't see a lot of these patients in my outpatient clinic. You might always think that this happens because when they do develop Parkinson's, maybe their migraine sometimes improves in life. But I do have a feeling that it is sometimes good to understand whether if diseases are correlated or not, that at a, you would say, clinical level. Because, as I said, it helps you sometimes be more aware of maybe asking about certain symptoms. If the opposite would have been true, so I could imagine myself being interested in how sleep goes, whether if they have some REM sleep disorders or anything that might also be, for example, a prodromal symptom of Parkinson's. And if this is not the case, maybe unconsciously, I'm not as interested in asking about these things when I'm with a patient. So that's the big takeaway. Just it gives you a better view of the complexities and comorbidities of migraine and how, as a clinician, you can be a step forward of the expression or the severity of these diseases and how they present themselves.
And we do have to take it with a little bit of a grain of salt because we know the biobank was based on codes, right? And that also goes more to support some of these large collaborative studies that are very clinically guided.
The problem with what happens currently in research is that, as you say, there is less quality in very large cohorts. So better quality, you would say, of how the data is recorded and the experience of the clinician and so on in smaller cohorts. But for certain studies, especially all of these genetic studies, you need the large cohorts. And then, yeah, as you say, taken with a grain of salt, because this hemorrhagic stroke, for example, study also surprised me. So the good thing about these things is that suddenly you become a bit more aware, as I was saying, and you start being more, you observe a little more whether if this might be also at least happening in your clinical environment, you would say, so in your hospital.
I guess since we're talking about migraine, we should also talk about what we learned about CGRP inhibitors. We know that there was a recent label update from 2025 on elevated blood pressure as a potential side effect and Raynaud's phenomenon as well. What do the large real-world studies show, as well as some of the open label studies?
In open label studies, we are understanding how anti-CGRP therapies in general, although most of the real world is based on the antibodies because they were launched earlier and there is more experience and more publications. But we are seeing now long-term data, 2-year real world data. And for example, it has been seen that in real world, this is currently in press, but was communicated, as you were asking me at the beginning in the congresses, that actually long-term better response to anti-CGRP antibodies is not correlated to being obese, depressed, and having many of these comorbidities that we have just mentioned. So actually, there are less chances of becoming a 50% responder or more at long term if at baseline, if you are, for example, obese or you have depression. So that was one of the findings in the largest, I would say, long-term real-world cohort. It's called the Eureka study, and which has been now, as I was saying, accepted to be published in Neurology. And this will happen now in the first term of 2026. Then mentioning depression, however, an important study was also published this last year. It was communicated in the end, I would say, of 2024, but published in 2025 in JAMA Neurology. And this is a UNITE study, which was a randomized controlled trial with fremanezumab. And actually, patients who had major depression also responded to fremanezumab in comparison to placebo. And not only migraine, after only 3 months of double-blind phase, so fremanezumab against placebo, patients were improving in their migraine frequency and scoring and PROs, but also they were improving in their depressive symptoms. So I sometimes wonder whether if we should start considering depression as actually a migraine symptom, or whether if really it is a comorbidity. And it might be both depending on the patient.
Yeah, this was very interesting because as we think, and many of our guidelines would suggest that maybe with people that have migraine and depression, think of tricyclic antidepressants, SNRIs, but patients have a lot of disability. It's certainly reasonable to think about CGRP monoclonal antibody. And that is really a shift in thinking.
Oh, yeah, definitely. We have to start being aware of that. Actually, this type of findings in real world have been also seen, which is the fact that when you treat migraine properly with anti-CGRP therapies and Botox, I believe too, depressive symptoms improve. And you never know if it's really the consequence or is it, as I was saying, a part of the disease or what is linked with what. So it's quite interesting. Then we had the Preclude trial. And then if you want, I can end with the migraine kind of space there, showing that onabotulinum toxin A, so Botox, actually hasn't shown a difference in comparison to placebo in episodic migraine. So those are not too good news.
And we should also mention that there are a number of other neurotoxins that are still being investigated for episodic migraine prevention. And while it certainly could be just it's not effective in episodic migraine, there's less allodynia and so forth. It could also be the injection paradigm as well. So it would be very interesting to see if the other trials also are negative or not.
Yeah, exactly. I didn't mention those because they have not been communicated yet. They are still ongoing around the world, but we are in phase 3 trials of several toxins that are being tested both in episodic and chronic migraine. So yeah, more news to come for this year because I'm sure they will be probably communicated either at the end of this 2026 or beginning of 27.
Why don't we talk about cluster headache?
So in episodic cluster headache in the United States, but not in the rest of Europe, we have galcanezumab, which has been approved from the trials that were published in 2019 in the New England Journal of Medicine. And this experience has been shared in different real-world cohorts where galcanezumab is being used as a treatment of refractory episodic and chronic cluster headache with different case series around the world. But of course, those are not data that come from double-blind randomized controlled trials. So with this data, eptinezumab was tested and trialed in an official randomized controlled trial for episodic cluster headache, and actually the trial was negative. I believe that this happens because we still have to really figure out how we are going to measure when and how the primary outcome, and then of course the secondary for the cluster headache trials. Because if you look at the findings, most or all of the secondary endpoints were favored eptinezumab over placebo, but the primary outcome, which was the change from baseline in the number of weekly cluster headache attacks in weeks 1 and 2, so very early within the start of the treatment, was not positive. So it is important that we all kind of work together to find the best trial designs for cluster headache because there is a lot of need of finding new therapies for cluster headache patients.
I agree. Work in motion, definitely for cluster headache. Why don't we step back and look at the different guidelines and position statements that were published in 2025, and if we can create a theme for headache medicine.
I believe that probably the most important collaborative effort that has been done until now was published in this 2025. Led by the International Headache Society, we have published the global practice recommendations both for the acute and the preventive pharmacological treatment of migraine. They have been published in Cephalalgia, and they actually have been published in a more extensive, you would say, version and in an abridged summary version, which could be or can be useful for quick consultation. It gives you, in an optimal way, you could treat patients, or in a minimum way at least, treat them in all of the different questions, you would say, or with this question answer format that actually is very helpful for clinical practice. And on top of that, it highlights the fact that many of these therapies are not yet in the essential medical list of the WHO. And we also, as a society, in the International Headache Society, are working to be able to push forward many of the therapies which we think should be as we were saying, essential for patients or people with migraine around the world. However, in this effort, which we have done to actually increase the number of therapies that are included in the essential medicine list of the WHO, cluster headache has actually increased the number, I would say, of therapies associated or that can be given to cluster headache patients. And oxygen, verapamil, and sumatriptan have been included as essential therapies by the EML published in the WHO. And those were news that we found out after summer. Then I wanted to highlight also the non-invasive neuromodulation guidelines that are evidence-based. And this non-invasive neuromodulation is something that we are starting to see more and more, have more and more devices that are available for patients. And in this also collaborative effort, we have tried to summarize the evidence that we have for their indications, for the ages of use, for the mode of stimulation, and also the potential mechanisms of action. So that's an interesting also guideline to know of or know about. And finally, I wanted to highlight two position statements that have been published by the IHS, the International Headache Society. One is related to having higher standards for migraine care, which actually promotes the fact or really highlights the fact that if you have a patient who has 20 days of migraine and you improve a 50%, which is very good, they're still left with 9 or 10 days of migraine. And we wanted to write this paper to highlight that we believe that's still an insufficient control of the disease. And there have been already real-world studies showing that in a typical high-frequent chronic migraine cohort of patients, only around 40% of patients receiving anti-CGRP therapies can achieve optimal control after 6 months of therapy. And optimal, according to the IHS, is a person who has less than 4 days with migraine or moderate to severe headache. Only 40% of patients currently being treated around the world with anti-CGRP therapies arrive to this optimal control. So we have to do something else. And this is why the International Headache Society wrote a second paper and a second position statement paper where they wanted to make sure that we are starting to think of starting migraine preventive therapy earlier or sooner than later. And probably shifting or making a mind shift way of thinking in how the paradigm of how we treat migraine patients is or will change in the future. Probably, I would say, moving from preventing attacks to really understanding that we have to prevent disease progression or the attacks from happening. So basically, we are moving into an earlier treatment for migraine individuals because it is very difficult sometimes, if not to really help them, if they have already become chronic.
If you wanted to leave a take home with our practicing neurologist about advances in headache medicine, what would you say is the final summary?
First, we have at least, as far as we know, 3 different new therapeutic targets being studied in phase 2 trials. As a reminder, PACAP, anti-PAR2, and we also have all of the new toxins that are being currently, as you were mentioning, studied. So hopefully new therapeutic targets with their therapies and clinical developments for migraine in, we would say, near future. The second big takeaway message is that migraine seems to be a very inflammatory disease that could be modulated by epigenetics, and that might also lead to some therapeutic advances or diagnostics in the future. And finally, we have to remember that there are excellent guideline and practice recommendation papers that are very helpful. First, to be very acquainted and updated with all of the practice recommendations and therapies that we can offer patients around the world, but also are making sure that we as clinicians treat our patients with migraine sooner than later within the evolution of the disease. So if anyone remembers this, they will be very updated in the migraine field and headache field also. Thank you again for the invitation, and I hope to be able to keep on updating you every year.
You're so good. We're going to have you back next year.
Yeah, thank you, Tish, and thank you for your trust.
Thank you again, Patricia. I'm always enjoying our conversations. And thank you for listening. Please check out our entire headache series. I promise it's excellent.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.